Recording in progress. Hola, muy buenas tardes a todos. Sean muy
Hello, good
bienvenidos
evening, everyone.
al webinar de
Welcome
este martes 9 de agosto,
to the webinar of this
presentado por el Colegio
Tuesday,
Mexicano
August
de
9th,
Neuroespecialistas en
by
la
the
Consulta
Mexican
Crónica de
College
Asma.
of
Mi nombre
Specialist
es Mónica Rodríguez,
Pediatricians in
coordinadora
Allergies and Immunology. I'm Dr. Mónica Rodriguez. I'm
de Compedia,
Secretary General of
y bueno, es
Compedia.
un gusto para mí
And it's a
presentarles
pleasure for
el
me to
tema que se
bring
va a
you
llevar a cabo el día de hoy.
today's
Un tema
topic.
realmente relevante
This
por
is
toda la
something that
consulta
is
de
very
allergólogos,
relevant
de pediatras
for
y de enfermeras que nos
allergologists,
atendemos
pediatricians,
a
and
diario
colleagues, all of us who
no
take
solo
care of
aquí y en
children
demás
in
países
our country
de
and
América
other
Latina y
countries
del
in Latin
mundo, uno
America
de los
and
principales
throughout the world.
problemas crónicos que
Chronic
padece la población
problems
general, pero enfocado
of
en
the
los
general
pacientes pediátricos,
population, but also
pues
focused
el
in the
sobrepeso y la obesidad.
pediatric
Entonces, les
population.
agradezco muchísimo conectarse el día de hoy. También a quienes nos
Thank
visitan
you for joining us today.
el
And
streaming en
also,
vivo.
if you
Y
follow us in
quiero
live
comentarles,
streaming,
bueno,
I
la
want to
traducción de hoy
mention
pues será
that
en
today's
materia de
session
inglés.
is going to be
También
in
tenemos la suerte de
English.
contar con la
We are
participación en vivo
very
de la doctora
fortunate to
Hendrickson
have the
para la
live
moderación de los
participation
eventos
of
especialistas,
Dr.
finalizando
Hendrickson
la
for the
presentación de
Q&A
su plática.
right after her
Y
presentation. And
contamos con
we
la
also have
posibilidad de traducción simultánea para quienes
simultaneous
deseen
interpreting.
escucharlo
If
en
you
idioma
want to
original o en español.
listen in
Entonces,
the
bueno,
original language
bienvenidos
in English,
aquí a
or
este
if you want
streaming.
to
Y pues
listen
los
to the
detalles
interpretation
los
into
pueden ver
Spanish. These are
referidos
the
en
instructions
pantalla.
that we have on the
Y
screen.
al mismo
At
tiempo,
the
abajo
bottom of your screen, you can
del
see a
botón
globe,
pueden accesar
and you can
al idioma
click
que
and
ustedes
choose
seleccionen,
the language of your
en
choice
inglés o en español.
in English or in Spanish.
También quiero aprovechar
I want
para
to take this
dejar dicho
opportunity
todas
to
mis
continue inviting you. You can still sign up to the International course of Immunology,
desde la última semana de
Advanced,
mayo,
Basic,
pero
and Clinical, and started
nos
on May
quedan
25th.
todas
But the
que se
sessions
pueden
are
como
all
recuperar gratuitamente
recorded,
desde las
and you can
plataformas
play them on
del
demand
curso.
or live
Y
in the platform
pues
of our
bueno, en realidad
association.
es un
And
curso del que hemos recibido muy buenos comentarios
this is a
y que
really
tiene
good
muy buenas
course.
mejoras
Everybody is
para
very
beneficio de todos
happy,
ustedes.
and it could be
Entonces,
very
los
useful
invitamos.
for all of you. So we
Bueno,
invite you
quiero
to
presentar
sign
a la
up.
doctora
I want to
Sarah
introduce
Hendrickson.
Dr. Sarah
Ella es médico
Hendrickson.
egresada de la Escuela de
She's a
Medicina Pediátrica de
graduated
la
physician
Universidad
from the
de
School
Harvard.
of Medicine from
Estudió
Harvard.
pediatría
She
y
specialized in pediatrics and later on
clínica
in
pediátrica
clinical
en el
immunology and
Hospital
pediatrics
Pediátrico de Filadelfia, donde
at the Children's
actualmente
Hospital in Philadelphia, where she's currently
profesor de pediatría.
associate professor and
Está
professor of
afiliada
pediatrics.
a
She's
la
affiliated to
American
the
Association
American
of Allergic and
Association of
Immunology,
Allergy, Asthma, and
American
Immunology,
College of Alergia,
the
Asthma
American
and
Association
Immunology,
of
American
Immunologists, American
College of
College of Allergy, Asthma, and
Allergy,
Immunology, as
American
well
American
as the
Pediatrics.
American
Ha
Pediatric
ganado
Association.
diferentes
She has
disciplinas, es
received different
además
awards. She's
muy
also
académica, ha
really
participado
active
en
in the
90
academia.
publicaciones,
She has
es una
participated in more than
consejera de
90
posgrado
publications. It's a
en
pleasure
SILAC,
for us to
titulada
bring you this
Comorbidities in Asthma,
presentation,
con enfoque
Comorbidities in
específico
Asthma,
para
focused
el
on
fenotipo de asma y obesidad.
obesity
Entonces,
and asthma.
pues vamos a
So
escuchar
let's
la
listen
presentación y terminando nos vemos para
to
la
today's
sesión de preguntas y
presentation, and
respuestas.
then at the end,
Muchas
we're going to
gracias.
have our Q&A. Thank you so much.
Thank the organizers for the opportunity to present our work today. I'll be discussing the effect of obese asthma on immune function. I have no conflicts of interest that are relevant to this talk. We're going over the basics of immune health and immune dysregulation, talking about obese asthma from a basic perspective, and then diving into our research study into pediatric obese asthma, and then concluding. Let's start with immune health. We lack data on the metrics and tests to really help us understand the fundamental aspects of immune function. And what do I mean by that? What does it mean to think about a normal immune response, be it in a child, an adult, an asthmatic, an obese patient? We don't know what those basic normal values are in the sense of individual key nodes or the network as a whole. And so we still need to define the key networks that underlie human immune function before we can truly understand dysfunction. It's not that we don't know how to collect a lot of data. Immunology at the bench has an amazing capacity to generate big data, be it transcriptional, flow cytometry, epigenetics. When we go back to what's in the clinic, there are very few clinically available tests that we can connect those research data to. And even if we stay within the research data, there's a lot of complexity that we haven't yet reduced to an understanding of the key nodes and pathways that control immune health at baseline and how those are changed in the setting of disease. When we think about pediatric disease, and as a pediatric allergy immunology provider at the Children's Hospital of Philadelphia, we recognize there's even more challenge. Children's immune state evolves as they age. Here, looking at a collaboration with Jeff Gerber and Sagari Makapati at CHOP, where we sample newborn patients by blood, looking here at their CD3 T cells using immune profiling. And as those same patients age, we see dramatic changes in the balance of their T cell subsets. So just the axis of time in the setting of pediatrics adds more complexity. Beyond the state of normal, as we might call it, or healthy or baseline, we also have perturbed immune states. For example, chronic inflammation like obesity and or asthma. By perturbing the immune system, we learn more about the control points that control it at baseline in health and where we might want to target our therapies in disease. So how do we do that? In our particular lab and in many labs, we recruit and start from understanding what's going on in patients. So we recruit in our own group from healthy patients as well as patients with disease, in this case, patients with asthma and obesity. And then we look at alterations in immune state by using peripheral blood mononuclear cells. We use flow cytometry, we use transcriptional studies and metabolic studies to understand how the immune system is working and how it's altered in the setting of disease. Then we bring together that data and try to understand what we can learn across the different modalities that we've measured. And then we loop back through using hypotheses that come out of our initial investigations. And this can be either using mouse models or human cells in vitro, depending on the question we're trying to ask. And we feel like we've gotten to the point where our hypothesis testing has given us a mechanism to better understand disease diagnosis or treatment. We could bring that back to people and patients in our clinics in the future. So let's talk about obese asthma specifically. Chronic inflammation in pediatrics encompasses many different disease states. Asthma and obesity are two of the most common inflammatory diseases of childhood. In the US, there's about a 9% prevalence of asthma and almost 20% prevalence for obesity. And both are more common in non-Caucasian children and in children in low-income families. And around the world over the last few decades, both of these diseases have increased in prevalence. This is looking at obesity in the United States, and here seeing the prevalence of least to most severe obesity. We can see increases over approximately 20 years. And then if we look worldwide, where red triangles are increased and blue triangles are decreased and green is no change, we also see increase in pediatric asthma around the world, here looking at 13 to 14-year-olds. Now, if we start from the perspective of obesity, we know that obesity has strong effects on the immune system. However, though that's something that's widely stated and understood to be true, it's actually more complex. From a review we wrote recently, where we looked at the primary data for alterations in immune cell subsets, serum cytokines, adipokines, and metabolites, there's actually a dearth of information, especially in pediatrics, on what exactly is different and whether there are many different subgroups of obesity that may affect immune system differently. We also want to think about the function of the immune system. So even more complicated than simply counting up the cells subsets and their frequency and how much of the different serum cytokines and adipokines and metabolites are present. How are the cells working? How activated are they at baseline? Do they respond properly to vaccination? Do they respond properly to vaccines and infections? So for some respiratory viral infections, especially in the setting of the COVID pandemic, we're very aware that there's worse morbidity and mortality in obese patients. And this is true in both kids and adults. For example, in the H1N1 flu pandemic, as well as COVID-19, we see an increase in risk as someone has greater BMI or body mass index. And this is data that's replotted from Hamer et al. In an editorial piece in Science in 2020, showing that as you increase your BMI in adults, you increase the frequency of hospital admissions, and this was early in the pandemic. However, this isn't as clear across a range of infections and severities of infection. So it's not always the case that being obese yields worse outcomes. In addition, there's quite limited data on vaccine responses in obesity, especially in kids, but also in adults, although there is some evidence of reduced response or retention of a primary response to tetanus, hepatitis B, and influenza vaccination in various publications, there's quite limited primary data that has BMI information connected to it. So this aspect of function remains really kind of in question in an active area of research. So if we think about the cellular immune system specifically and how the state of chronic inflammation and here obesity affects the baseline state of the immune system, one of the things that's been shown in the last few years is that there's upregulation of inhibitory receptors on CD8 T cells in obesity. And here we see PD-1, which is an inhibitory receptor, increased on CD8 T cells in non-human primates. And this is connected in this paper to the idea of melanoma patients. And in melanoma patients, we see a state of T cell exhaustion, which I'll come back to, where you have chronic antigen and chronic inflammation in the setting of cancer. Your T cells increase the expression of inhibitory receptors, which tone down their ability to respond to the cancer properly. And what we see here is that our obese patients who have higher amounts of one of these inhibitory receptors, known as PD-1, actually do better when they're given checkpoint blockade that turns down that negative response. So in patients where they've turned on an inhibitory receptor that prevents proper response to their cancer, and then they get a checkpoint blockade that turns off that off signal, they get better improvement in survival than their non-obese patients in the same study. And so not only may there be alterations in the activation state of our obese patients at baseline, it has implications for how they respond to therapies like checkpoint blockade in a cancer treatment. Now, if we come to the connection between obesity and asthma, we know that the majority of obese children will become obese adolescents and adults, and they develop the comorbidities, those children, of obesity at younger ages, which makes sense. They start obesity earlier than those who become obese in adulthood. And so they start gaining these comorbidities of obesity as children. And asthma can be considered a comorbidity of obesity for some patients. There's definitely asthma that comes on not in the setting of obesity, but as BMI increases, as body mass index increases, the risk of developing asthma increases as well. And so in the United States, while a little more than 20% of US school-age children are obese, almost 30% of asthmatic children are obese. And if we look at the connection between weight, and this is showing in blue underweight, healthy weight, overweight, obese, and very obese patients from a paper in AJRCCM, we see that the asthma prevalence increases as your weight increases. We know that asthma is not a single disease, especially in the context of an allergy group. But we know that it is a set of overlapping clinical phenotypes. So we talk about age of onset, we talk about presence of neutrophils, EOs, the connection with smoking, and the presence of obesity. But these are potentially overlapping states. We know that obese asthmatics have poor response to preventative therapies, and though they may not get more exacerbations of their asthma, what they have are severe viral exacerbations when they have them. With regard to prevention, this is one paper of many showing the percent of days that are controlled, that asthma is controlled, based on whether patients are on inhaled corticosteroid, placebo, or montelukast. And you can see that these are less effective as BMI increases. So it's not clear how obesity is altering the immunometabolic state in asthma, but we do have a sense that not only is it harder to prevent these patients from flaring, when they do, those flares are more significant. And could that be a result of poor ability to respond to viral infection in these patients? And how would we think about what that would mean for the immune system? So if we think about obesity modulating the immune response in asthma, as I mentioned, we know that obesity is an independent predictor of developing asthma. We know that in obese asthma, we talked briefly about obesity on its own and its effect on the immune system. Obese asthma, if you go into the literature there are documented differences that can be quite variable in the literature about how T cells are activated, what the differentiation state is at baseline, their cytokines in their serum, the metabolites in their serum, and then also thoughts about where the adiposity is located, when it comes on in life, and the roles of sex hormones and other differences that may contribute to the morbidity and mortality we see in obese asthma. So how can we think about the existing literature of altered immune function in obese asthma? So there's limited literature in T cell skewing in obese asthma, and it's likely that obese asthma is another umbrella So it's not that everyone who has obesity in the setting of has asthma in the setting of obesity has the same disease. And so once again, we are humbled by the complexity of medicine. There are wonderful studies looking at type 1 skewing in obese asthma. And what you can see here, we're looking at interferon gamma secretion by obese asthmatics being increased compared to non-obese asthmatics. And here we can see that the IL-4 is elevated in non-obese asthmatics compared to obese asthmatics, and then the ratio of interferon gamma or type 1 immunity is increased compared to IL-4 or type 2 immunity in our obese versus non-obese asthmatics in this paper from Rastogi et al. There's also in addition, clearly subgroups of obese asthma with type 2 immune skewing. Some of the evidence along these lines is that we see good response to anti-IgE therapy in our obese asthmatics, which is a type 2 therapy. There's very fascinating important roles for IL-33 and innate lymphoid cells in type 2 phenotypes and in type 2 immunity in obese asthma. There's also fascinating data showing here on the lower right from Fahey et al. Showing that in adults with severe asthma, we see an increase of plasma IL-6 that scales along with BMI and plays an important role in obese asthma. And so there's many alterations in obese asthma. And there's some differences between pediatrics and adults. And I'm feeling that it's probably more complicated than we originally thought. And most likely, this is another example of a clinical phenotype that may have multiple endotypes, multiple mechanisms within it. So if we think about the presence of chronic antigen stimulation in the setting of inflammation, so to take a pivot, let's think about how T cells can fail to work. How could we have patients struggle to fight off respiratory viruses? So one thing we know about is a state called T cell exhaustion, where you have a persistent antigen and persistent inflammation. For example, in the setting of cancer, in the setting of chronic infection. In a normal situation, when we see an acute infection or vaccination, the antigen here in red comes up. T cells here in purple proliferate, they recognize the antigen, they get rid of it, and we keep a small population of memory cells for the next time it comes back. But when we have chronic infection or cancer, we're not able to get rid of the antigen and the inflammation, and the T cells become exhausted. And what does that mean? T cell exhaustion, it shows changes in the level of T cell inhibitory receptors. I spoke briefly before about the presence of something called PD-1, which is one of those inhibitory receptors. But there are many cell surface markers known as inhibitory receptors, CTLA4, LAG3, TIGIT. The details don't matter here. But we change the nature of the signals being received by the T cell by increasing the expression of negative signaling molecules at the start. There's also changes in transcription and epigenetic voice, and all of that together leads to changes in function. And so the T cells don't work as well when all of these changes take place. And so they're less able to deal with the infection, to deal with the tumor. And so the question here is it possible that this is an issue that our obese asthmatics are facing because of the chronic inflammation that they have in their bodies because of the obesity? And is it possible that the inflammation of asthma adds to that and worsens the situation you might have in obesity alone? So if we think about obese asthma specifically, there's a wonderful paper a few years ago looking at how CD8 T cells, so historically we often think about CD4 T cells and type 1 immunity, type 2 immunity. CD8 T cells have recently been investigated in obese asthma as well. And so when this group looked at sputum and the transcription in the sputum, they found that there were changes, a number of different changes, but in the obese patients and the obese asthmatics, they found that there may be alterations in the ability of the CD8 T cells to work properly. And we know that those CD8 T cells are responsible in part for fighting off viruses. And so could this contribute to the kinds of clinical phenotypes we see in our obese asthma patients? Now, there's also a contribution of immunometabolism. And what does that mean? How do the metabolites and the mitochondria, the balance of metabolites in the serum and cells, and how well the mitochondria are working in our immune cells, facilitate or make it harder for the immune system to work properly? As I said before, we know that asthma flares are most often caused by upper respiratory viruses. Why are our obese asthmatics getting sicker when they get those viruses? As we discussed, historically, asthma has been thought of as type 2 skewed, but we know that there's a large proportion of patients that are non-type 2 skewed. And historically, obesity has been seen as type 1 skewed or type 17 skewed. but it's become quite clear that it's much more complicated. And that bringing those together in obese asthma, where you have both properties present, it's been quite complicated as to what kind of overall tone the immune system has. So when we say type 2 skewing, we're thinking about CD4 T cells that are Th2 cells and secrete IL-4, 5, and 13, as well as innate lymphoid cells. Type 1 skewing, we're thinking about an increase in type Th1 CD4 T cells, which secrete interferon gamma, as well as ILC1s. But we also have changes in the metabolites in the fluids and breath in our body. And we see them individually in asthma and obesity on their own, as well as in obese asthmatics. And we're learning what the effects are of these differences. For example, there's a lovely study from a few years ago looking at exhaled breath condensates from patients that are obese asthma or asthma. So things that are over the 0 line are higher in obese asthma, things below the 0 line are higher in lean asthmatics. And you can see that there's differences in these metabolites in these particular patients. But what does this mean, and how does it affect how the immune system works? And of course, it may affect other systems as well, here focusing on the effect on the immune system. So if we dive in deeper, we know there's many ultrametabolites in obesity, especially short chain fatty acids like acetate, as well as changes in tryptophan pathway members. And we know there's also alterations in asthma. And so let's take a look at some of the data. In a paper that I was a co-author on, decreased tryptophan pathway was found in obese mice and humans. And here you can see this is indole, and it's decreasing from healthy to different classes of obesity in humans. And then we also know when we think about short chain fatty acids, here looking at secretion of IL-17 versus interferon gamma. So this would be Th17 cells versus Th1 cells. When we compare control cells to those treated with acetate or with propionate, 2 different short chain fatty acids, we see an increase in Th17 secretion, in Th17 cells, or an increase in IL-17 secretion. So when mouse CD4 T cells are treated with acetate, for example, we get more Th17 cells. So the addition of a single metabolite, one that can be altered in the setting of obesity, can change dramatically the nature of the CD4 T cells exposed to that metabolite. So let's talk about a specific study that our group undertook to give you a little more in the way of details. So in this particular study, we recruited obese asthmatics, obese only, and healthy control, so non-obese, non-asthmatics. And we performed a variety of studies, including looking at their vaccine responses, their serum cytokines, their serum metabolites, the nature of their T cell activation state and subset balance, and their clinical metadata in terms of how healthy they were, and what kinds of admissions and allergies they were experiencing. So if we look at the demographics for the study here, just looking at the obese asthmatics and the non-obese asthmatics, we can see that we have relatively a balance between males and females. Our age is right around 10 years. We required patients to be at least 6 years old, so they are past the age of having received their childhood vaccinations, because we're going to come back to that later. We recruited these patients from around our institution, and this predominance of African-American patients is consistent with the Philadelphia area and our CHOP protocol, our CHOP, population. And both asthma populations, the obese and non-obese, were recruited from our allergy clinic at CHOP. They were recruited based on their BMI percentile, so you can see that's elevated in the obese asthmatics. And you can also see that the great majority of both asthma populations is atopic, whether you use allergic rhinitis, whether you use the presence of medications for allergic rhinitis as opposed to the diagnosis, or you use the presence of allergic rhinitis or eczema as diagnosis codes. By multiple definitions, these are atopic populations. The obese non-asthma and the non-obese non-asthma populations had a much lower rate of atopy. So if we just think about the basic metabolic parameters in obese asthma, you can see that, not surprisingly, our BMI percentile, which is how we think about BMI in pediatrics, we use the BMI percentile rather than the absolute body mass index number. So it's corrected for sex and age. You can see that there's an elevation, as you would expect based on our recruitment strategy, of the BMI in the obese asthma and obese groups. We also were interested to see that we saw an elevation in the CRP, the C-reactive protein, in our obese asthma group only, not in our obese only group. And that was compared to the asthma and healthy control patients. And then, not surprisingly, we had elevations in leptin for both obese groups. We then undertook deep immune profiling of our patients. And so just to go through the basics, much like traditional flow cytometry, where you use fluorescently labeled antibodies, here we perform cytometry based on antibodies that are labeled with elemental isotopes, with metals. And so this allows you to use many more simultaneous antibodies. And the reason is, with fluorophores on your antibodies, eventually the emission spectra overlap, and you can't have infinite fluorescent antibodies in the same vial in the same flow cytometer. Although that's improved since the study was conducted. This particular strategy allows us to measure more than 40 markers simultaneously, and we measured 43 parameters, and you can see our panel on the left. So you use your metal labeled antibodies, and they used by essentially the same sort of staining protocol one would use for fluorescent flow cytometry, where you have cell surface and intracellular labeling using your metal labeled antibodies. And the cells are put through an argon plasma, and that basically creates a cloud of ions. We ignore those that are expected to be in human cells, and those are depicted in black, paying attention to those that are not expected to be present in human cells, and the amount of each of those ions and the presence in the individual cell cloud tells you how much of your individual epitopes were present on the cell when it was intact. And so this is a way of measuring many aspects of a cell simultaneously, more than one could get with a fluorescent strategy. And so this is known as CyTOF. So having conducted CyTOF in PBMCs from our 4 patient groups, there's 2 analysis strategies. One is to use traditional manual gating. So you're looking for the presence of cell subsets that you're anticipating being interested in. CD4, CD8s, naive, non-naive, Th1, Th2, those kinds of differences can be readily detected and measured by traditional manual gating. The other strategy is to learn what you're not anticipating. And so here we take these 43 dimensions, which no one's capable of thinking in 43 dimensions, and use a dimensionality reduction algorithm. We used phenograph. And then cells that are similar to each other across multiple parameters are brought physically next to each other in this clustering strategy. So here you can see where every dot is a cell, clusters are colored and then numbered. And so here we have a number of clusters that have been determined by the phenograph algorithm. And then you can take each cluster, so this is clusters on the y-axis, and look at the markers here on the x-axis and determine what type of cell is in each of these clusters. And that can be done either manually or in automated fashion. And then you say, okay, if I put in the same number of cells from healthy control populations and disease populations, I would expect if a given cluster, let's say cluster 12, doesn't matter that this disease is not affected by this disease, I put in 50-50, half healthy control cells, half asthmatic cells, I would expect cluster 12 to then be half of each if it has no effect on the disease and is not affected by the disease. But what you can see here is that this is clusters on the x-axis and the fraction of that cluster on the y-axis that's from the 2 different groups. And we can see some clusters are almost all healthy control, for example, in green, and some clusters are almost all asthma, as seen in red. And those clusters that are most skewed to the disease or healthy state, or if there's multiple disease states to one or the other, does not mean that they're causing disease, but it means that they're either affected by or important for the disease and worth thinking about more. And again, these might be clusters, types of cells that you had not thought about and your manual gating would not have allowed you to access. So this is the discovery potential of deep immune profiling. So here looking at obese asthma only, and healthy controls, again, each dot is a cell from one of these 4 groups, and this is the same map across the 4 groups with the cells showing only from the patient group of interest. On the right, we're showing what's called a galaxy plot, where the more orange or the less black you see, the sort of higher the topography is, the more cells there are in that particular cluster. And I've highlighted a few numbered clusters where we see big differences between, for example, healthy control and obese asthma, or obese asthma and healthy control to go in the opposite direction. So this is just showing you the broad differences. Now, if we step into 2 major patterns we saw as being different in this study. The first was, interestingly, we saw an increase in type 2 immunity in obese asthma, which is not exactly what we were expecting. And how do we read that out? There was an increase in CD4 T cells that are CRTH2 positive on our CyTOF, which is one way of marking Th2 cells. We saw an increase in serum IgE levels in obese asthma compared to all groups, and an increase in IL-13 in the serum, again, compared to all 3 groups. So by multiple modalities, we found this difference. We also found differences in CD8 T cells. So what I just showed you was type 2 immunity, CD4 T cells, here CD8 T cells, we saw alterations in inhibitory receptors like PD-1, CTLA-4, as well as differences in Helios and EOMES, which is a memory marker, between our groups of interest. And so we wanted to dive in further. And so first we started with a difference in type 2 immunity. So to better understand the role of serum metabolites, we looked at a range of water-soluble and lipid-soluble metabolites in our patients. This is just showing those that are significantly different between our 4 groups. And here we're interested in OA versus all other groups. And we focused in on glutamate. And though it was highest in our obese asthmatics, there was a significant trend of increasing glutamate levels as BMI Z-score increased. So not simply BMI percentile, but the BMI Z-score, another way of looking at pediatric body mass index data. So we focused in on glutamate because there was evidence in the literature of a direct connection between glutamate and type 2 immunity. Glutamate is not able to transfer through the cell membrane. So measuring serum glutamate means that it must be signaling at the cell surface. It cannot cross that membrane. And so it can either signal through ionotropic glutamate receptors or through metabotropic G protein coupled receptors. So we were specifically interested in canic acid, and I'll come back to that. So there was a published paper looking in B cells, human B cells, showing that as you add glutamate agonist, here canic acid, with the undashed line, you get more IgE from your culture. If you add glutamate, you also get more IgE from your B cell culture. If you start with peripheral blood mononuclear cells and you add glutamate to your culture, you get more IgE. But if you block specifically the canic acid receptor, so not all glutamate signaling, just the canic acid receptor signaling, you lose that increase in type 2 immunity. You lose that increase in additional IgE. And so if we activate glutamate signaling and specifically canic acid, we get more IgE from B cells or PBMCs. But this has nothing to say about T cells. And so we were interested in the effect of canic acid on healthy control human T cells. And so here we're looking at increased doses of canic acid at the ratio of IL-13 as a type 2 immunity marker over interferon gamma as a type 1 immunity marker. And you see an increase in the ratio of type 2 immunity to type 1 immunity as you increase the dose of canic acid over a 7-day culture that included CD3, CD28 beads. We also found that our obese asthmatics had low acetate levels in their serum. Specifically, when we dove into mouse work that we had been doing, we noticed that if we treated with extra acetate, we got extra IL-17 out of our cells. And so we were curious, with low acetate, would we see low IL-17 from our patients? And we did. In our obese asthmatics, we had a trend towards a reduction in obese asthma, where we saw a low level of acetate in their serum. And then when we took healthy control T cells and we treated them with acetate, we were able to show an increase in the production of IL-17 by CD4 non-naive T cells during those cultures. So we have clear links between altered metabolites and 2 different forms of CD4 T cell differentiation, linking to the data we found in our obese asthmatic pediatric patients. Now, we also wanted to understand T cell exhaustion in obese asthma. So again, I discussed before that when you have an acute infection or vaccination and you clear that antigen inflammation, your T effector cells are also able to apoptose, leaving you a small population of memory cells. But when you cannot clear the antigen inflammation in the setting of chronic infection or cancer, you can get T cell exhaustion. And what does that look like? Changes in inhibitory receptors like PD-1 coming up, changes in transcription and epigenetic state, and decrease in appropriate T cell function. I had mentioned before, but just to remind you, in obese patients, it's been shown here in a population of patients with melanoma with a specific form of solid cancer, that there's an increase in PD-1, a specific inhibitory receptor, in a population of non-human, there's an increase in PD-1 T cells, and that's shared across threes and CD3 T cells that are CD4 positive or CD8 positive in this particular case. And I had mentioned before that when these obese patients are treated by targeting this inhibitory receptor PD-1, they have a better improvement in their clinical state than non-obese melanoma patients treated with the same therapy. In addition, when we look at obese patients who are coming for bariatric surgery, here looking at the ability of these cells to produce interferon gamma, TNF alpha, IL-5, or IL-13, pre-surgery on the left, whether they do not as controls or do as asthmatics, 12 months later, with less adiposity, Now the obese asthmatic patients who were resampled, the control patients were not, but the obese asthmatic patients were resampled. Now they have an increased ability to secrete all of these different cytokines. So it may be that the presence of obesity in the setting of obese asthma is a part of the reason why the cells aren't working as well as we expect them to. And as I said, a decrease in function can be characteristic of an exhausted state. So this is just sort of circumstantial or literature-based evidence that maybe obesity and perhaps even obese asthma has a component of T cell dysfunction, which may be exhaustion, but none of this proves that. So we looked just in our obese asthma versus our asthma patients. Again, here each dot is a cell. Here, this is our what we call galaxy plot showing how much of those individual clusters are present in our asthmatics versus our obese asthmatics, just looking at T cells. And what we found when we looked at the clusters, and here I'm just showing the clusters that look exhausted. When we look at these clusters between our obese asthma and asthma patients, we see increases in the exhausted-like clusters in our obese asthmatics compared to our asthmatics. And specifically, we saw a consistent increase in effector memory-like cells, effector memory cells that express granzyme B, TBET, EMS, and PD-1 and had lower levels of Helios and TCF1, which can be consistent with an exhausted state. So we see changes in immune phenotype, but is this reflective of exhaustion? And in order to know that, we need to test function. Now, this is challenging. It's hard to test antigen-specific function in T cells in humans because we don't know the different antigens they've been exposed to in the past. So what can we do? We turned to vaccine responses. So we know that over the course of a person's immunological life, they have planned medical interventions like vaccines, as well as unplanned medical interventions, including infections and other perturbations. And that can be assayed by many different strategies in the lab. So we looked back to data from the Slivko lab from 2007, showing the decrease in titers to tetanus and diphtheria over time. Now, unfortunately, this data did not include BMI for these patients, but we know that our antibody responses, and we test this in clinic, of course, for our clinical immunology patients, have a normal rate of decay. And then there are patients that we worry about who have an abnormal rate of decay or have a lack of good primary response. So here we looked at the titers in our patients for tetanus, diphtheria, Prevnar, and H1N1 across our 4 groups of obese asthma, obesity, and healthy controls. And we found, interestingly, that the only group with a decrease in protection to a specific vaccine was our normal weight asthmatics in the setting of Prevnar, as well as our non-obese, non-asthmatic patients in the setting of flu. So first, what we looked at is whether there's a connection between the presence of exhausted-like cells and whether they kept their vaccine responses. And so how do we do this? This is looking at a correlation between each of these, which are the different clusters. So every number here is a cluster of cells, not an individual cell, a cluster of cells. I've written what it looks like in terms of the phenotype of the cluster next to the number. So cluster 9 is a CD4 T effector memory exhausted-like cluster. And then we look at the connection between BMI Z-score and whether you kept your vaccine protection. And fascinatingly, as your BMI goes up, we see more CD8 exhausted-like clusters going along with elevated BMI. And when we look at vaccine protection, we see more CD4 exhausted-like clusters going along with vaccine protection. And in those that are lower weight and have less vaccine protection, we see a connection to innate-like clusters like NKT cells and gamma delta T cells. So we thought this was kind of the opposite of what we expected, a hyperactivated cluster or an exhausted-like cluster going along with better retention of your vaccines. Again, we did not vaccinate any children in the study. We're looking at whether they kept their childhood vaccine responses. So we found 2 different adult cohorts and looked at non-obese versus obese vaccine protection. And here again, we found a trend towards an increase in retained vaccine protection in the obese group in this cohort on the left. And then in data from the Milieu Intérieur, a French cohort that did not recruit obese patients, only recruited up to overweight patients, there was a connection for rubella to predicted retention of protective rubella serostatus with more elevated BMI, but again, they did not actually have obese patients in this cohort. So we've since then moved on into mouse models. We really want to understand function more deeply, which requires infecting a mouse model. So we're looking at 4 groups of mice: obese asthma, asthma alone, and healthy controls. Our obesity model is a high-fat diet model. And so our asthma model is exposure to house dust mite. The reason we're using a dietary model of obesity rather than a genetic model of obesity, for example, the OB mice or the DB mice, where the leptin or leptin receptor are altered genetically, is that we know that there's a direct effect of leptin on T cell function, and that's been well elucidated in the literature. And while we know leptin is altered, and I presented that data earlier for this pediatric cohort, we didn't want to add that additional complexity by focusing only on a change in leptin as opposed to the sort of more broad effective diet in these animals. So we're using a 60% high-fat diet model for these animals for this study. And we treat for a prolonged period. Here we treat for 6 weeks, and they're treated intranasally for 5 days out of 7 every week. And they're on control or high-fat diet for more than 25 weeks. And we then look at the lung and spleen when we sacrifice the animals. And I'll show you here just the very beginnings of this study, which I don't have time to go into all the details of, but we see an increase in our high-fat diet and PBS-treated or high-fat diet and HDM-treated mice with regard to an exhausted leg population in PD-1 and EMS double positive. And so we're trying to understand better the connection between obesity and obese asthma and exhaustion in different mouse models of obese asthma and obesity. So this is one model we've looked at. We've looked at a couple models using males, using females, and using different timing in order to better understand this work. So next, we're going to look at the impact on infection responses. So in conclusion, we found in the literature has shown this for years and it continues to evolve now, the immune system is altered in the setting of obesity. The immune system is altered in the setting of asthma. Neither of those diagnoses are one molecular mechanism. They're very complex with roles for the environment, for genetics, for diet, for infection. And when we bring those two together in the setting of obese asthma, at that intersection, there's even more complexity. But we know that our obese asthmatic patients struggle with severe viral respiratory infections. And in our own study that we reported here, having shown that the literature represents that there are many changes in metabolites in the serum, there's a range of differences in the T cells and the innate lymphoid cells and the serum cytokines. So many different possible alterations that can be found in these patients. In this particular study where we looked at allergic asthmatics that were obese and allergic asthmatics that were non-obese, we found more type 2 immunity in our obese asthmatics, which may mean that the CD4 T cells are less well poised to fight viral infection. And we found more CD8 T cell dysfunction, especially alterations in the immune phenotype, and getting into the question of how function is poised in these patients. And it could be that this could set patients up to not fight viral infections properly. Now, our data around the vaccine responses with better retention of those patients, it is possible that though we can detect antibodies against those vaccines, that they may not be high quality antibodies. And it may be that the T cells that responded to those vaccines do not work as well. Or it may be that what we see is sort of an exhausted-like state in these patients. Perhaps it's actually a hyperactivated state. And so we have so much to learn from the mouse models that we're developing about what exactly is going on in the setting of chronic inflammation due to obesity and asthma. And we're really excited to understand that better with a focus on the change in ability to respond to infection as a way of thinking about function kind of as a summary. What do the cells, what cells are there? What do they look like at baseline from an activation state, and how well do they work? We also found that our atopic obese asthmatics had differences in their metabolic state and their serum metabolites. And 2 examples I went through today were changes in glutamate and changes in acetate. And we were able to step out of the patient and treat healthy control T cells from other patients, from other research participants, and show that we could recapitulate some of the differences we saw in our obese asthma patients by just treating healthy control cells with one metabolite, whether it was glutamate signaling, which we used canic acid for, or acetate. And we could drive changes in short-term cultures just by changing the concentration of single metabolites to better reflect our pediatric atopic obese asthma patients. So much left to be learned. And I appreciate the opportunity of sharing with you what we shared with you today. Again, from our perspective, starting from patients, and in my case, starting from pediatric patients, understanding the immune differences in those patients, diving into the mechanism, in this case, both in vitro in healthy control T cells, as well as in mouse models, will hopefully bring us back to the potential to better treat our complex pediatric patients with obese asthma. I'd like to thank my lab. There's a picture of us at a recent celebration enjoying the nice weather, as well as my collaborators across CHOP and Penn at Princeton and Duke, including the Rabinowitz lab and the Schmader group. I'd like to thank our funding sources and the families who participated in our study. And thank you so much for your attention. I'll be happy to take questions. Thank you.
Thank you very, very much, Dr. Henriksson, for being now with us, and thank you for the excellent talk. And it's a very, very important topic for all of us to try to understand. So I will begin with some of the questions. One of them is about the reversibility of either the quantitative or the functional impact of obese asthma. What's it in real life for the patients? We cannot listen to you. Thank you.
Sorry about that.
Thank you.
The data that we have in humans is that, and it's in adults, is that if your obesity comes before your asthma and you get bariatric surgery to reduce weight, that you can see improvement in the asthma with the weight loss of the bariatric surgery. If your asthma comes before your obesity, treating the obesity with bariatric surgery does not affect the asthma. So in terms of weight loss being the answer for asthma in the setting of obese asthma, it seems more true if your asthma comes up as a complication of your obesity rather than the opposite. And we're doing a study right now looking in adolescents who need bariatric surgery. In the US, our institution at least, we're currently offering bariatric surgery down to age 16. And so we're looking in these older adolescents, 16 through sort of low 20s, to see if we see a similar effect. In kids, as I mentioned in the video, asthma is often allergic in nature, as we all know. And so it's not, and that's more so than we see in adults. And so it's not clear whether we'll see different patterns or the same patterns with the effect of bariatric surgery. With regards to the patterns we saw in the research study around whether an exhausted-like pattern could be reversible, we're still learning about that right now in mouse models. So we're looking at blocking PD-1, one of the receptors that is a part of exhaustion, either by antibody or in knockout mice, to see if that will improve either the asthma or the immune function or both, using flu infection in mice as one of our strategies. And then the last way of thinking about this question is though not all obese asthmatics are type 2 skewed, the ones that we were studying here were from our allergy clinic. And as I showed, the majority of them were allergic asthmatics. And it's been shown now in many patients, both pediatric and adult, that even if you're an obese asthmatic, and the way that drugs like Xolair are licensed in the US, there can be a maximum BMI, for example, for the drug. But it's been shown that even in quite obese patients, including in kids, that type 2 therapies can be very effective for treating asthma should you be a type 2 skewed obese asthmatic. So I think one of the messages that I've learned is that much like asthma is an umbrella, obese asthma seems to be an umbrella, and we have to think about really subtle differences between our patients and not, find new umbrellas to be distracted by.
Thank you very much. There is another question, a lot of questions at the live chat. There's another one about if the impact of chronic hypoxia that the obese patients may have.
Such a great question. So another study we're doing with the bariatric patients is looking at the T cells in the adipose tissue where we know there's hypoxia. And we are using single cell RNA sequencing to look at the lymphocytes in the blood and in the fat, and then comparing the blood before the bariatric surgery to after the bariatric surgery to try to understand better the impact of weight loss. So that kind of local tissue hypoxia, we don't know yet. The other place where we've looked at it is you can use a hypoxia chamber with cell culture, and we've just gotten that in our lab. And so we're looking at trying that as well. It's been shown in mice that in a tumor where there's more hypoxia within the tumor, that hypoxia seems to lead to an exhausted state or to contribute in the setting of antigen being present, like in a tumor. Hypoxia plus chronic antigen can make exhaustion more likely. And so it may very well connect to obesity as well. And that's definitely something we're interested in. So it's a really great question.
Thank you very much. There is another very interesting question here at the chat. Besides thanking you for the fantastic talk, they ask about if patients with asthma and obesity, and well, we should discriminate among obese asthma, if they have a predominant, for example, Th2 phenotype, if they can change to a Th2 phenotype when they lose weight. Also, can we actually expect to see these different skewing of the T effector cells? And there's another one from the same person about the role of vitamin D.
Yes, those are both really important questions. So for the first one, what we saw, so what we sort of expected to find was that non-obese asthma would be type 2 and that obese asthma would be Th17 or Th1 in nature. By starting with these allergic asthmatics that were also obese asthmatics, we were seeing less Th17 and more Th2, but there have been other papers that have shown a merging of Th17 and Th2 in obese asthma, other papers that have shown type 1. So I think it's very dependent on some of these other factors. And one of them I think is allergies. In our mouse model, when the mouse model that we're using, as I mentioned, is house dust mite and high fat diet. Depending how we change the duration of the house dust mite, the age of the mice when we look at them, as well as those are the two main factors. We can see more of a blended Th2 and Th17 phenotype, and kind of that's affected by all of these different aspects of the model. So I'm not yet sure about losing weight, and this study that I mentioned where we're going to collect blood and fat at the time of bariatric surgery and then blood 6 to 12 months later will help us understand that. The paper in adults by Ann Dixon's group in 2011 doesn't show it. There's probably not sufficient patients in that paper to make a comment about that, but they showed better side. The other issue is when you have exhaustion, you have less cytokine secretion overall. And so if weight loss improves effector function and changes skewing, then there can be some complexity there. So I would say right now, we don't know from the data, but that's something we'd like to understand better. I haven't worked directly with vitamin D. I know there's a lot of investigators who have, and I think it's a really interesting question.
Thank you. And also coming from the other chat, besides the role of vitamin D, also there have been very interesting studies on the supplementation with high doses of omega-3.
Yeah, we haven't. It's such all fascinating questions. So we've looked in vitro, as I showed you. We looked at the brief treatment with the with acetate and glutamate. We haven't tried treatment with omega fatty acids either in vivo or in vitro, either in mouse or in human. But all great questions. And I wish what often ends up being the case is that people who do these sort of treatment studies don't often save extra cells. So it's often really hard to go back and ask another question of the study. So I'm not aware of biobank samples, but it would be fascinating to look if someone had done a study like that for a different reason and those questions could be asked. But we haven't done them ourselves, and I haven't seen the data that relates directly to T cell dysfunction.
Thank you very much. They also ask about some of the information, some of the available information on Latino patients.
Yes, so the role of race and ancestry in these findings is really very important. We know that in Black and Latinx patients that there are higher rates of asthma as well as obese asthma. There's fascinating studies in a Puerto Rican population that is studied by a group in Pittsburgh. The challenge that we have at our institution is in Philadelphia. Our city has a certain degree of geographic segregation, and there are more Hispanic and Latinx patients who go to another children's hospital in a different part of Philadelphia. And so our team really wants to reach the whole representative population of our city. And so we're working on strategies to build bridges with community groups in the Hispanic and Latinx group so that we can better understand that question. But right now, recruiting from, not that CHOP doesn't have any patients, but we have less representation than we would like to in the setting of wanting to understand this disease and the city in which we live in better. And so we're actively trying to build bridges with groups that will help us understand the answer to that question. But my data from our particular group has very limited participation from that particular ethnic background. And so we're working on that. But it's so important. And I think one of the things that we've noticed is differences between when studies are conducted in different institutions, depending on the racial and ethnic diversity in the study and in the city that the study is derived from. When we see differences, it's hard to know whether those relate to race and ethnicity, whether they, what of the many differences between studies are important for the scientific outcome. But that's definitely a difference between the small number of studies in pediatric obese asthma. And so it's definitely something that we want to do a better job of going forward to understand that more deeply.
Thank you very, very much. There are still many questions coming in. I have personally one. How should we expect the response to allergen immunotherapy in our either obese and obese asthmatic patients?
That is such a great question. I'm curious if I've not seen studies of that. That is such a great question. I mean, I think even the mechanisms of, well, OIT as well, but for allergen immune therapy still remain to be perfectly elucidated. And I think that's fascinating in of itself, but that I have not seen studies on that, but that since what you're anticipating is the development of tolerance, not necessarily involving CD8 T cells as we're studying here, although we did see clear effects on fours as well. We didn't really study the humoral system here. That's a really great question, and I don't have an answer, but I would love to know. That's fascinating.
Really, really interesting, because well, of course, of us as allergists and pediatricians, one of the main resources to control our patients with the allergic phenotype, of course. There's another one about the lung function tests and the outcomes in either the obese asthmatics and the non-obese asthmatic patients. This one from the chat. Thank you.
Such a great question. So there have definitely been studies as well, considering whether obese asthma and the sort of severity, we don't see more viral infections, but we see more severe illnesses when our patients get viral infections for their asthma flares. And one of the discussions that's in the literature is whether obese asthma is more about the physical restriction of the chest cavity by the adiposity, preventing full expiration and inhalation. And definitely a lot of opinions and data looking at alterations in lung structure and alterations in the elastic and compliant properties of the lung tissue itself. In our particular study, again, with a small sample, we didn't see statistically significant differences in the extent of baseline obstruction. But I think one of the things I realized when I was looking at the study is that having spirometry pre and post albuterol at the time of diagnosis is not always performed. We always have spirometry, but not always with the use of albuterol, and we definitely don't have methacholine challenges for very many of our children at all. And so our information in this setting of a non-clinical trial, in the setting of sort of an observational study, it's hard to have perfect information, but we did not see statistically different findings for lung function testing. And so we can't connect the immunological findings to the lung function testings in a way that's insightful here. But with a larger study that was done in order to target this question, I think that would be a really important component of the clinical metadata to connect to the immunology.
Thank you very much. I have another one. Maybe we can take 2 more questions.
I'm free as long as you need me.
Thank you very much. And another one on the role, well, it's also like a very interesting thing in terms of the microbiome and obese asthmatics, and how obesity may lead to a skewed microbiome, but then the microbiome can also, if we look from the other way around, we can also expect a certain microbiome, and well, of course, the impact and the role of nutrition and diet to also be like a major risk factor, let's say, for obesity.
Yeah, I mean, all of those are such important questions. We have not done a lot of work ourselves in the microbiome, and it's definitely not one of my areas of expertise. I've worked on a study looking at IgA deficiency at the role of the microbiome, and it's remarkable. And as the question mentions, there's so many. We know that your microbiome can make you susceptible to obesity. It's kind of independent of diet, and if you receive a healthy weight microbiome, that your weight can improve with the same diet in animal studies, at least. So definitely, I agree that all of those things are interconnected. We have not taken stool samples from our patients, and I have not seen microbiome studies in obese asthma, but I could definitely have missed them since it's not what we directly study. But I think it's so clear that, especially from like a systems immunology perspective, all of these things are connected. And studying one, you always have to acknowledge that you're missing others, and acknowledge the importance of all the individual pieces. So I would love to understand that better, but it's not something that I have any particular insight into from our own work.
Thank you very much. They are also asking about certain biomarkers, if they've been studied among the population at CHOP, for example, and they specifically ask for the relationship between FGF21 and also the relationship between exhaled fraction of oxynitrate.
I haven't looked at FGF21, and our institution has not started using FeNO clinically. And so I didn't have FeNO from the clinical record to include. So we had skin testing, we had lung function testing. All of that was what was in the clinical record. It was not done as sort of as a trial. I started the study when I was a fellow. So this was a study that started from the clinical metadata that existed and invested in generating the immunological data. But both are fascinating. And I think it would have been lovely to connect the type 2 immune signature with FeNO if we had measured that. That would have been fascinating to see if that corroborated our finding of increased blood evidence of type 2 immunity. But unfortunately, we don't have either of those data points.
Thank you very, very much. I think that with this question, we can finish our session. Not before thanking you again for this excellent talk, and also for this fantastic Q&A session that will be very, very useful for our daily practice, and also to inspire any further research lines also among our patients here in Mexico. So any final comment from you, Dr. Henriksson?
Yeah, absolutely. If anyone wants to reach out with any questions, I'm more than happy to take those. I don't actually have access to type my email, but if I'm happy to have that shared with the group or with anyone that is interested in my email. It's just my last name and my first initial @chop.edu. So just Henriksson s@chop.edu. So happy to answer any questions that I can if we weren't able to cover them, or if anyone wants to talk about any of the content from today anytime.
Thank you very much. We will share your email at the live chat with the participants. And well, thank you very, very much, and greetings to Philadelphia. And we hope to have you on a near future in any further academic events, maybe face-to-face. Thank you very, very much.
That would be lovely. Thank you again for inviting me. I'm very honored to be able to join you tonight.
Bye-bye.
Bye.
Bueno, agradecemos muchísimo a la doctora Henriksson y vamos a compartir su correo por si alguien quiere.
We thank Dr. Hendrickson, and we're going to share her email if somebody wants to contact her later. And we're going to be sharing you the link for the questionnaire for today. And the last announcement that I want to share with you is that we're going to have a joint session with the Mexican Association of Pediatricians and specialize in immunology and allergy, and this is going to take place on August 30th, 2022. August 30th, the College of ENT and Head and Neck Surgery, COPEME, and the and Compedia. As you can see, we're going to have excellent professors to talk about this important topic about how to choose treatment in allergic rhinitis. So we will see you on August 30th and have a good night. Thank you.